Welcome back to RX Russia Pharma Basics. Today we are doing a full comparison of the 6 SSRIs you will see most often in practice: fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluvoxamine. Same mechanism of action but very different clinical personalities. By the end of this episode, you will know exactly how to tell them apart on kinetics, indications, withdrawal risk, and warnings. Here is the clinical problem. All 6 of these drugs block the serotonin transporter, so the textbook mechanism is identical. But if you switch a patient from paroxetine to fluoxetine, everything about how you counsel them changes. Half-life differs by almost 6 days across the class. Some are potent CYP inhibitors, others are clean. Withdrawal risk is almost entirely predictable from kinetics, and the FDA label footprint ranges from 1 indication to 7. That is what we are unpacking today. Let us start with pharmacokinetics, because this is the foundation for almost everything else in this episode. Fluoxetine has a apparent half-life of 4 to 6 days, and its active metabolite, norfluoxetine, can stick around for 4 to 16 days. That is by far the longest in the class. Sertraline sits at 26 hours with a weak active metabolite. Paroxetine is 21 hours with no active metabolite at all, and it actually inhibits its own metabolism. Citalopram is 35 hours. Escitalopram is 27 to 32 hours, neither with a significant active metabolite. Fluvoxamine is the shortest at 15 hours. Here is the clinical pearl. Half-life is the single biggest predictor of both drug interaction burden and discontinuation risk. Keep that in mind as we go. Now let us talk about CYP450 inhibition, because this is where SSR is really separate from each other. Paroxetine and fluvoxamine are the 2 most potent inhibitors in the class. Paroxetine hits CYP2D6 hard, and fluvoxamine is a potent inhibitor of both CYP1A2 and CYP2C19. Fluoxetine is also a potent 2D6 inhibitor, largely through its long-acting metabolite norfluoxetine. Sertraline is a mild, dose-dependent 2D6 inhibitor, and citalopram and escitalopram are the cleanest of the group, with minimal CYP inhibition overall. If you have a patient on multiple medications, this chart alone can guide your first choice. Let us look at FDA-approved indications, because this is a place where the class really is not uniform. Fluoxetine covers major depression, OCD, panic disorder, PMDD under the brand Sarafem, and bulimia. Sertraline covers major depression, OCD, panic disorder, social anxiety, PTSD, and PMDD. Paroxetine has the broadest label in the class, covering major depression, OCD, panic disorder, social anxiety, generalized anxiety disorder, PTSD, and PMDD. Citalopram, on the other hand, is approved for major depression only. Escitalopram adds generalized anxiety disorder to major depression, and fluvoxamine in the United States is approved specifically for OCD. So citalopram has 1 indication and paroxetine has 7. Same drug class, very different regulatory footprint. Let us talk about why stopping an SSRI can actually feel like withdrawal. When you block the serotonin transporter for weeks or months, the receptor system adapts to that blockade. If you stop abruptly, reuptake resumes suddenly and synaptic serotonin signaling rebounds. The speed of that rebound tracks directly with how fast the drug clears the body. Common symptoms include dizziness and vertigo, brain zaps, which are electric shock-like sensations, irritability and anxiety, flu-like symptoms, insomnia with vivid dreams, and other sensory disturbances. A useful mnemonic here is Finnish: flu-like symptoms, insomnia, nausea, imbalance, sensory disturbance, and hyperarousal. Now let us rank the 6 SSRIs by withdrawal risk, because this directly follows from what we just covered on kinetics. Paroxetine and fluvoxamine carry the highest risk since both have short half-lives, and paroxetine specifically has no active metabolite to buffer the drop. Sertraline, citalopram, and escitalopram sit in the moderate risk category with mid-length half-lives, and fluoxetine is the clear outlier at the lowest risk end because its long half-life essentially self-tapers the patient. This is one of the most testable and most clinically useful facts in this entire episode. Let us move to tolerability, because this is often what actually drives a patient's choice or a prescriber's second attempt. Sertraline has the highest rates of GI upset and diarrhea in the class. Paroxetine is the most sedating, causes the most weight gain, is the most anticholinergic with dry mouth and constipation, and has the highest rates of sexual dysfunction. Fluoxetine tends to be the most activating, which can mean insomnia and an early anxiogenic effect before things settle. Citalopram and escitalopram generally have the most favorable overall tolerability and the lowest interaction burden, and fluvoxamine brings significant GI upset on top of a heavy CYP1A2 and CYP2C19 interaction load. Here is a boxed warning every prescriber needs to know cold. Citalopram carries a dose-dependent risk of QTc prolongation. The maximum dose is 40 mg per day in standard adult patients. That drops to 20 mg per day in patients with hepatic impairment, in elderly patients, in CYP2C19 poor metabolizers, or when citalopram is combined with a CYP2C19 inhibitor. And citalopram should be avoided entirely in patients with congenital long QT syndrome. Escitalopram carries a related but milder signal, but citalopram is the one with the explicit labeled dose ceiling. Now let us cover paroxetine in pregnancy, because this changes first-line prescribing decisions. First trimester exposure to paroxetine has been associated with an increased risk of fetal cardiac malformations, most notably septal defects. The clinical implication is that paroxetine is generally avoided as a first-line choice in patients who are pregnant or planning a pregnancy. If a patient is already stabilized on paroxetine and becomes pregnant, that requires a careful, individualized risk-benefit conversation rather than an automatic switch. And remember, paroxetine also carries the highest discontinuation syndrome risk in the class, which matters if a switch is being considered. Let us close out the warnings with what applies to every single SSRI in this class, regardless of which one your patient is on. Serotonin syndrome risk rises sharply with certain combinations. The highest risk pairings to flag are MAOEs, triptans, tramadol, and linezolid. Beyond serotonin syndrome, counsel on an increased bleeding risk, especially when combined with NSAIDs or anticoagulants. Watch for hyponatremia from SIADH, particularly in elderly patients, and remember that every SSRI carries a boxed warning for increased suicidality risk in patients under 25 years old. These three risks are not drug-specific, they are class-wide, so they belong in every SSRI counseling session. So how do you actually match the drug to the patient? If your patient has renal or hepatic impairment or is already on multiple medications, citalopram or escitalopram are usually the safest bet because of minimal CYP interference. If adherence is a concern and missed doses are common, fluoxetine's long half-life acts as a built-in buffer. If your patient has comorbid OCD or panic disorder, sertraline or paroxetine offer the broadest indication coverage. If your patient is pregnant or planning a pregnancy, avoid paroxetine given the cardiac malformation signal. And if there is a cardiac history or QT concern, avoid citalopram or at minimum respect the dose cap. Before we wrap up, let us talk about STAR-D, because this is the trial that shaped how we think about real-world SSRI response. STAR-D stands for Sequenced Treatment Alternatives to Relieve Depression, and it is the largest real-world antidepressant effectiveness trial ever run, using citalopram as the first-line agent. About 1 in 3 patients achieved remission on citalopram alone at step 1. Cumulative remission climbed to roughly 67% after multiple treatment steps. But here is the catch. Remission rates got lower at each successive step, and relapse rates got higher the further down the treatment algorithm patients went. The clinical takeaway is simple. Set realistic expectations at the first trial and build in measurement-based follow-up, rather than assuming one SSRI will be the final answer. Now let us talk about a special population question that comes up constantly. What do you do with a depressed patient who also has cardiac disease? This is where SADHART comes in, the sertraline antidepressant heart attack randomized trial. It studied sertraline specifically in patients with a recent myocardial infarction or unstable angina. The results showed no significant effect on left ventricular ejection fraction and no increase in cardiac events compared to placebo in that population. That is why sertraline has become the go-to SSRI after an MI or acute coronary syndrome. One caveat worth remembering, sertraline is still a mild CYP2D6 inhibitor, so it is worth double-checking interactions if your patient is on metoprolol or clopidogrel. But overall, cardiac history plus depression points towards sertraline first. Let us go one level deeper. Because the indication differences across this class are not random, they trace back to secondary receptor activity beyond simple SERT blockade. Fluoxetine blocks 5-HT2C receptors and weakly inhibits norepinephrine reuptake, giving it an activating profile. That is part of why it is the only SSRI approved for bulimia nervosa. Sertraline does have mild dopamine transporter activity, but that is a minor secondary effect pharmacologically, not a major driver of its clinical profile. Its strong standing in PTSD and social anxiety comes mainly from its trial evidence base and its favorable tolerability, not from that dopamine effect. Paroxetine has strong anticholinergic and sedating properties, which makes it useful for calming acute anxiety. But that same profile is tied to the harshest withdrawal syndrome in the class. Escitalopram is the most selective SERT blocker with minimal receptor binding extras, which means fewer drug interactions and better overall tolerability for mood and anxiety symptoms. Citalopram, its racemic parent compound, shares that same clean receptor profile, but its label has stayed focused on major depression. And fluvoxamine has a high affinity for sigma-1 receptors, which is believed to provide added benefit for the repetitive, intrusive thoughts seen in OCD. So the takeaway here is that indication differences are not just about potency or approval history. They are rooted in what else each molecule touches besides the serotonin transporter. Let us recap the 5 things to walk away with today. Number 1, kinetics drive almost everything in this class, including interaction burden, withdrawal risk, and dosing flexibility. Number 2, fluoxetine's long half-life is protective against discontinuation syndrome. Number 3, paroxetine and fluvoxamine carry the highest withdrawal and interaction risk in the class. Number 4, citalopram is dose-capped for QTC prolongation, and paroxetine is generally avoided in pregnancy. Number 5, serotonin syndrome, bleeding risk, and hyponatremia apply to the entire SSRI class, not just one drug. That is the full SSRI comparison. Real pharmacology taught the way you will actually use it. If this helped you study or helped you counsel a patient this week, drop a comment and let me know, which SSRI trips you up the most. Subscribe so you do not miss the next one, and I will see you there.